Hello, my name is Gwendolyn Caleb. My clinical site is RKM Primary Care located in Jackson, Louisiana. My case is Mr. 62-year-old HC, birthday 9/21/1958. Mr. HC is a 62-year-old African-American male who presents to the clinic with his sister, in which his sister appears to be a reliable historian. Mr. HC chief complaint is coming to the clinic for lab results, and he's complaining of some shortness of breath upon minimal exertion, and when lying down, he's complaining of feeling weak, fatigue, coughing with the clear nasal drainage, and he's complaining of some swelling to his bilateral lower extremities, which has been going on for about 2 weeks. He states that makes the shortness of breath a little better is when he's sleeping in an upright position or when he adds multiple pillows under his head during sleep time. His primary medical history is GERD, hypertension, arthritis, COPD, kidney disease, and he had a history of a GI bleed approximately a month ago. He's had multiple surgeries to his right arm, January of 2001. His vaccinations, he refused both the influenza and the COVID vaccination. His medications, amlodipine 10 milligrams daily, Protonix 40 milligrams daily, atenolol 50 milligrams daily, Periactin 4 milligrams TID, gabapentin 300 milligrams BID, Spiriva inhaler and the ProAir inhaler, and he takes sodium bicarbonate 650 milligrams TID. He has an allergy to penicillin in which it causes a rash. There are no seasonal, environmental, or food allergies. His family history: his mother is deceased at age 78 due to leukemia. His father, age 62, deceased due to lung cancer, in which he had a history of hypertension. He has an aunt, deceased age 61 due to brain cancer. His social history: he is widowed times 12 years, no children. He lives with his sister in a 2-bedroom apartment. Mr. HC is disabled. He drinks 4 beers daily on the weekends. He is a former smoker in which he stopped in 2006. He drinks 1 to 2 cups of coffee daily. No illicit street drugs. He has a 10th grade education. No past or current arrest or incarcerations. He does not participate in no exercise regimen. As far as ROS, constitutional. He denies fever, chills, significant weight loss, but he does report a weight gain of 5 pounds over the last couple of weeks. He does report feelings of fatigue. His ROS is unremarkable except the respiratory and the cardiovascular system. The respiratory system, he does complain of shortness of breath upon minimal exertion. He complains of a cough with a clear nasal drainage. He complains of swelling to the bilateral lower extremities. He does complain of a little muscle pain, joint pain, stiffness with decreased range of motion, and he reports some discomfort with the bilateral lower extremities due to the edema. His objectives: his vital signs 168/91, in which he reports forgetting to take his blood pressure medications this morning. Heart rate 70, respirations 20, temp 98.1, O2 sat 94% on room air. He denies any pain at this time. He's 5'9". He weighs 144.8 ounces, BMI 21.34. He had some blood work done the beginning of May, in which his renal studies were way abnormal. His most recent labs were May the 14th. His WBC count 9.5, RBC 3.96, hematocrit 36.5, hemoglobin 11.7, neutral 68, platelets 280, sodium 143, potassium 5.2, chloride 111, bicarb 36, BUN 80, and creatinine 4.27 with the BMP of 347. Objective-wise, Mr. HC is slenderly built. He's dressed appropriately for the weather. He's unable to maintain eye contact. He appears to be a little worried. ROS, everything is unremarkable with the exception of shortness of breath, accessory muscles noted. He's coughing with clear nasal drainage. Cardiovascular-wise, shortness of breath upon minimal exertion. There is some +2 pitting edema to bilateral lower extremities. His assessment: 62-year-old male with a history of GERD, kidney disease, hypertension, COPD, and arthritis with the complaint of shortness of breath upon minimal exertion, fatigue, cough, and swollen lower extremities. His differential diagnosis: acute exacerbation of COPD, pulmonary embolism, and CHF. I am going to diagnose Mr. HC with CHF because with the acute exacerbation, I'm going to rule that out because he is not having any green or yellow sputum, and he is not having no increased coughing, although he is coughing, but it's not frequently as someone with the exacerbation of COPD. I'm going to rule out the PE because with this, he is not having no type of decreased level of consciousness, no flank pain. And with the CHF, he is experiencing some edema to the bilateral lower extremities. He is having shortness of breath upon minimal exertion. He is having some fatigue and weakness with the cough of a clear nasal drainage. And there is some wheezing that's going on in his lungs in the lower base fields, both anteriorly and posteriorly. His plan of care is going to include for him to continue to take his current medications. I'm going to call refills in for his inhalers. I'm going to have an in-house EKG with some in-house labs to include a CMP, CBC, and a BNP. I'm going to refer him to the cardiologist, nephrologist, and a gastroenterologist because a month ago he had some GI bleeding going on. He did not follow up with the gastro. He did not follow up with the nephrologist, and I'm going to refer him to the cardiologist because with all of this renal stuff going on, his blood work with the renal studies is just really, really out of whack. So I would refer him to cardiology to have